So we have a debate on different situations in refractive surgery. So we first begin with low myopia, assuming that the patient is suitable after all the investigation for a refractive surgery. In a low myopic patient, less than 3 to 4 diopter, what would be your choice of refractive error correction? Dr. Syed Mazz would be talking for surface ablation, and Dr. Nitin Balakrishna would talk for Lasik for low myopia. So Dr. Syed Mazz, please. You have 4 minutes each, and after that there will be discussion by the co-chairpersons and a final verdict. So, I wanted to give a small prize for the person who gets the maximum vote from the audience. So please vote for your person whom you feel did the correct thing by doing the correct procedure. All our friends here.
Good afternoon, everyone. Thank you, Dr. Rupal, and everyone organizing this for this unique this thing. I think with the this is first for me to speak on water. We have always spoken on land. Now this is the first time we are speaking on water, and hope next time we'll speak on air. And the final would be underwater submarine sometime later. Right, yeah.
Anything
Space,
is possible.
anything is possible. We don't know. So, uh, for my fellow speaker, I think this is a no-brainer for me. Low myopia, I would definitely go for a surface ablation. How to go back? In this? Right.
Okay, the person who loses is going to be thrown into the water.
Okay.
Your choice.
So let's start with pre-op. In pre-op, low powers. If suppose someone, most of the patients who we get for low power corrections are the ones who want to join uniformed forces or are into contact sports. Then this is a no-brainer that you would do a surface ablation for them. Now, if you have a patient who's very anxious and you might have chances of suction losses, then again, a surface ablation would be the procedure of choice. Even if you have a bit of mild to moderate dry eyes, a recurrent corneal erosion, or an epithelial basement membrane dystrophy, in initial learning curve, a deep set eye would be an issue for someone to initiate the suction. And if there is any history of retinal detachment, I know that we are doing this in low myopes, but even if you have a history of retinal detachment in the family, it's always a good idea to do a surface ablation procedure. Back. And intra-op, everyone knows that. This is back. This is back. So intra-op, we all know that a surface ablation is almost a no-brainer, given the fact that our retinal colleagues tell us that when your surgery ends, our surgery begins. So they do a scraping and then their surgery begins. And when we do a scraping, our surgery ends. A procedure cannot be more short than a surface ablation. You might take about 20 seconds to ablate, and now with the newer laser, you might ablate in about 5 to 6 seconds. So a sub 1 minute surgery can be done. And now with the newer modalities, I don't need to say that there are already people advertising a lot about that on Google and YouTube about whatever we have, and I don't have any financial interest. So they are newer modalities by which people are also upselling the surface ablation by using newer and more fancier words. And in the post-op, definitely, if there is an overcorrection, we can modulate the wound response, which is not possible in a case of Lasik, by stopping your steroids and starting an NSAID. And that way, we can modulate the refractive outcomes too. So, and then finally, it is a very cost-effective way of doing it. The only cost would be the gas exchange which you take, and then you can do as many procedures as possible without any recurring costs of the LASIK surgery. And now, as if it was a very difficult procedure, people have made it more easier by having the trans PRK, where the only skill set required would be how to place a speculum, and after that the surgery is over. And then you can also give very nice fancy name to the procedure which you are doing. Last it will be PRK, but before that you can add any number of vowels and consonants to it, and also increase the cost of it. So this way I feel that surface ablation would be a better option than a LASIK procedure.
Speakers to please give one line of introduction to themselves before you start your presentation. So Mazz, you can introduce yourself. Just one line, huh? Not a paragraph.
Right. I'm Dr. Syed Mazz from Hyderabad, associated with Center for Sight. And doing refractive surgeries. That's
Which is the one to advance and go back. Okay. Yeah, this is advanced. Thank you. Thank you, Rupal. Lovely concept over here. I think Dr. Kudlu's brainchild, and this is a first-time concept. Like Dr. Syed Mazz said, the only thing I agree with him upon in this debate is that we should, from here, progress to air and to space and underwater and whatever else. I beg to differ with all the other things which he mentioned. So I'm Dr. Nitin Balakrishnan. I practice in Bombay doing refractive surgeries for the past 20 years. My guru and my teacher in refractive surgery, Dr. Rupal Shah, is right here in front of me. So this is something which I'm looking forward to. So let's define what is low myopia. We define low myopia as any myopia with 3 diopters or less. I agree with Dr. Mazz that suspicious topographies, thin corneas, procedure of choice would still be a PRK. Yes, no doubt about it. But a low myope with a normal topography, normal pachymetry, well, my first choice would definitely be a LASIK procedure. Now, the reasons for this is very simple. In the immediate post-operative period following a PRK, we very often, and we all have seen it over the years, in spite of wound modulation, in spite of various other factors, there is pain, in spite of the contact lenses with AccuVeil used, in spite of the MMC used, there is haze, there can be prolonged epithelial defects. Whereas in the immediate post-operative period following a LASIK, all that you have is nothing but a wow effect. In cases of PRK, the time needed to get a refractive stability is much longer as compared to a LASIK. At the same time, visual rehabilitation in LASIK is much faster. And most of these patients are young patients who cannot be told to avoid UV light. We all know that in a PRK, in order to prevent haze, we tell the patients to try and avoid UV light. None of these patients from Gen X are going to avoid the UV light, and therefore, there can be a risk of developing haze in these patients because of constant exposure to UV light. Again, professionals requiring medical fitness. Now, most of these cases with low myopia, maybe a point, even as low as a 0.75 or a 1 diopter, comes to you maybe about 10 to 15 days before they are going in for their medical clearance. I agree that this is a thing which need to be understood, that if LASIK is allowed in cases of the employment rules, if the employment rule says that LASIK is not allowed, I would definitely do a PRK. But if a LASIK is allowed for, as per the employment rules, for a quick visual rehabilitation, clear vision from day one, no development of haze, and therefore higher chances of passing a medical fitness exam. Again, clinical comparisons of LASIK, trans PRK, and SMILE for correction of myopia shows that the chances of regression, long-term regression, is much higher in PRK as compared to the other refractive procedures. So this would be my other point. A few points which Dr. Mazz mentioned, which I would like to take on. The first and the foremost is the risk of retinal detachment with the history of family history. Well, all our patients, whether they are low myopes or high myopes, we need to do a thorough examination of the retina, a thorough indentation examination in case there are suspicious areas which need to be treated. They need to be treated, and having done that, the chances of detachment even with a LASIK do not exist. They do exist, but they are as probably low as in any other case. The other thing was the cost factor. Well, all the fancy names, Streamlight and all, we need to pay a hefty cost to the companies. The companies skin you for your, literally skin you. So you're paying a hell of a lot of money just for those fancy names. So after having considered all this, I would say that in every case of low myopia, as long as the patient is fit for LASIK, my choice of the procedure would be a LASIK. Thank you.
Yeah, nice talk by both the people. I think let us, I think,
Take a vote.
Vote. There are 40 people are there. 40 ophthalmologists are there. If 20 each means both will be the winner. Otherwise, we will decide. I think for PRK, who and all tell that PRK is the best.
Please raise your hand.
1,
For low myopia.
1, 2, 3, 4.
Must be ready to jump.
4 for PRK. Okay.
Lasik?
For Lasik, yeah.
Wow.
Oh, that means I think everybody is telling that. Of course, I think both of them right. Also, I think Madam do agree with that.
So
It is once again depending upon the type of case, what you type of case, type of refractory error, and also the geographical distribution. Like I was always talking with Dr. Rohit Shetty, he always tell that people who practices in coastal area, we always tend to do less PRK than the Lasik just because of chances of haze is quite high. I even faced with some of the patient. In such patient, if you got a better option for both Lasik and PRK, I think we should go ahead with the Lasik only. Of course, thinking about the risk apart from haze, I think much less risk in PRK than definitely with the Lasik. Sometimes always till that microkeratome pass over, I think the heart will be like hitting for every surgeon that anything complication can happen, but it's likely to happen. If you think that, I think depending upon the case-based discussion, I personally feel that both techniques
I
are
agree
good.
with you that all the techniques do have some role to play in our. So we should have everything in our